Good afternoon. I've been invited to present on the question of who might benefit from extracorporeal CO2 removal. My name is Ewan Goligher. I'm assistant professor at the University of Toronto. These are my disclosures. I receive support in the form of research equipment from Goligher and Timpel and have received speakers fees from Goligher within the past 2 years. So one of the big challenges that we face in intensive care medicine is the problem of heterogeneity of treatment effect. A widely varying treatment response between different patients. And as a consequence of this, the interventions that we test in the study population seem to have, on the whole, no net benefit. So if you have a population of patients, some of whom benefit as represented in green, and some of whom do not benefit or even harmed as represented in red, the total net outcome appears to be no net benefit, and yet many patients within the population may have substantially benefited. And so this heterogeneity of treatment effect becomes an important problem when we're trying to decide which patients should receive the therapies that are available to us, and how do we prove benefit for the complex therapies we're trying to apply in the ICU. So one of the kind of paradigmatic cases where heterogeneity of treatment effect is an important problem is a new and potentially important therapy in respiratory failure known as extracorporeal CO2 removal. So this involves the application of an artificial lung which functions much like dialysis. In fact, it's often referred to as CO2 dialysis, in which at relatively low blood flows, CO2 is cleared through the extracorporeal circuit, and this can significantly reduce the ventilatory demands in the lung, because as CO2 removal is performed extracorporeally, then less ventilation, less tidal volume, less driving pressure, lower respiratory rate, and less mechanical power is applied to the lung. So in theory, this may substantially facilitate the delivery of lung protective mechanical ventilation. Nevertheless, ECCO2R, as it's commonly referred to, is extremely expensive, it's invasive, and it has an associated risk of complications, both from a vascular standpoint and from a bleeding standpoint. So ideally, we would identify patients who stand to benefit the most from ECCO2R and selectively apply the therapy within that population. Now, one of the ways that we can do that, one of the ways we can take account of this heterogeneity of treatment effect is by using the physiological response to an intervention to decide whether a patient will benefit from a clinical standpoint from that intervention. And crucially, for this model of selecting patients to work, the physiological response has to be closely linked to the mechanism driving outcome. So if you have a favorable physiological response, but it's completely unrelated to the mechanism that drives outcome, then it doesn't provide relevant information. But if you have a physiological response that is related to the mechanism, then it can help to inform whether a therapy is going to meaningfully benefit a patient or not. And I want to argue that we have such a physiological response with respect to extracorporeal CO2 removal. And that mechanistically relevant physiological response is the reduction in driving pressure. So together with Marcelo Amato and Art Slutsky, we were able to derive a physiological theoretical model that predicts a given patient's response to the application of ECCO2R. And along with factors such as device performance, which are really important determinants of how much CO2 you can remove, patient characteristics, including compliance and dead space, were shown to be key theoretical determinants of how much applying ECCO2R would reduce driving pressure. We had the opportunity to test this theoretical model in the context of a recently completed Supernova trial. And Supernova was a pilot feasibility trial where they took patients with moderate or severe ARDS, or rather just moderate ARDS, and applied ECCO2R with a goal of reducing tidal volume from 6 mils per kilo down to 4 mils per kilo. And this was done specifically in order to see whether the patients could tolerate this and actually achieve the so-called ultra-protective tidal volume. So we used this data set to analyze the variability in patient responses to ECOR. They enrolled 95 patients, and this trial was published in Intensive Care Medicine last year. So I mentioned two key factors that determine the heterogeneity of response to ECOR. And the first one I want to argue is alveolar dead space. Well, why would alveolar dead space fraction determine your response to extrapolar CO2 removal? Well, it really comes back to very basic respiratory physiology. If you have a lung with a relatively low dead space, then most of the CO2 that comes through that lung is going to be cleared by relatively small tidal volume. You can relatively easily ventilate off the CO2 coming into the lung because the lung's efficiency is high because the dead space is low. On the other hand, if you have a lung with a relatively higher dead space fraction, then you're going to need a larger tidal volume to ventilate off the same amount of CO2. So the lung is behaving less efficiently with a higher dead space and you need more tidal volume to clear the same VCO2. Now, if VCO2 were to increase, that means in the case of the first lung, you're going to have a relative increase in tidal volume, but the increase in tidal volume will be less in the lung with low dead space than in the lung with high dead space, because if VCO2 increases, you need relatively greater increases in tidal volume to maintain ventilation when dead space is high. Now, when you apply ECOR, what you're doing is effectively reducing VCO2. You're reducing the apparent VCO2 that the lung sees. And so we can imagine basically doing this backwards. So consequently, when you apply ECOR in the first lung with a low dead space fraction, you have a relatively smaller reduction in tidal volume. And when you apply ECOR in the second lung with a high dead space fraction, you've got a very large reduction in tidal volume from the right to the left. And so this is the way in which alveolar dead space fraction determines the magnitude of reduction in tidal volume you can obtain for a given amount of CO2 removal. And this is shown here in this figure where using predictive modeling, we predict the tidal volume in patients with varying levels of dead space with a permissive hypercapnia strategy on the left or with ECOR at a relatively high rate on the right. And so what you can see is the patients with relatively low dead space can get to tidal volume of almost 4 mils per kilo without the application of any ECOR, just by accepting a relatively lower pH and a higher respiratory rate. Whereas patients with high dead space can't get below 6 mils per kilo. In fact, on average, their tidal volume is slightly above. Now, when you add ECOR to this strategy, you'll see that you have some further reduction in potential reduction in tidal volume, maintaining the same respiratory rate and acid base targets. But in patients with high dead space, you have a much larger reduction in tidal volume from 6 all the way down to 4.5. So this highlights the way in which applying ECOR will have a variable effect on tidal volume depending on the level of dead space. And that's exactly what we found in the Supernova data. So here you can see this very clear correlation on the left between the change in the observed reduction in tidal volume and the estimated alveolar dead space fraction. And you see a similar relationship for driving pressure and for mechanical power, although the latter was not statistically significant. So hopefully can convince you that alveolar dead space fraction is an important moderator of the effect of ECOR on lung protective ventilation. Now we'll move to respiratory system compliance. So respiratory system compliance is important because it reflects the size of the baby lung available for ventilation. The smaller the baby lung, the lower the respiratory system compliance because the fewer lung units available to participate in ventilation. And this is important from a lung protection standpoint because the degree to which reducing tidal volume reduces stress and strain depends on the size of the baby lung. So take patient A with a relatively large baby lung, a high end expiratory lung volume. Decreasing tidal ventilation, shown in the orange boxes, from 6 down to 3, will have some effect on the stress and strain applied to the lung. But it's actually much less than in patient B, where end expiratory lung volume is very low, And relatively speaking, the same reduction in tidal volume has a much greater reduction in overall stress and strain within the lung. And probably the best parameter of stress and strain that we have readily available at the bedside is the driving pressure. And as you know, several years ago, Marcelo Amato and colleagues demonstrated that driving pressure was strongly associated with mortality, more strongly linked to mortality than tidal volume per se. So this suggests that driving pressure is a key determinant of stress and strain. And if so, then the benefit of lung protective ventilation will be greater the more that driving pressure is reduced. So we also found that the effect of ECCO2R on driving pressure varied according to respiratory system compliance. And this is not particularly surprising since driving pressure and compliance are mathematically linked, but it highlights the fact that a patient with a low respiratory system compliance will obtain a much greater reduction in driving pressure from a given amount of ECCO2R than a patient with higher respiratory system compliance. Similarly, there's a much greater reduction in mechanical power when you apply ECCO2R in patients with low respiratory system compliance. So if driving pressure or mechanical power, these measures of stress and strain and total energy load within the lung are the key determinants of lung injury, then a patient with low compliance is going to obtain more clinical benefit than a patient with high respiratory system compliance. So if you put all these patients in Supernova on a map of their distribution of respiratory system compliance and alveolar dead space fraction estimated through an empirical technique, you can see a wide scattering of the patients. Some patients have very low dead space, some patients have very good compliance, and the patients vary widely. And the patients who had the greatest reduction in driving pressure are represented here in the top right corner. So who benefits from ECCO2R from at least a theoretical physiological standpoint? It's patients with the highest dead space fraction and the lowest respiratory system compliance. And I would point out that the severity of hypoxemia did not predict the magnitude of these physiological benefits in multivariable analysis, suggesting that we should be targeting ECCO2R based on compliance in dead space rather than the traditional marker of ARDS severity, which is the severity of hypoxemia. In closing, I would note a key caveat. Physiological benefit does not necessarily entail outcome benefit, and this has been repeatedly emphasized in our field in important editorial statements. And I think we're all appreciative of that physiology can be very seductive, but that clinical trials are necessary to confirm that there really are important outcome benefits in the patients with the greatest potential physiological benefit. But nevertheless, because we have so much evidence that the driving pressure is a mechanistically relevant response, we have reason to be confident that trials designed on that basis could be successful. So to conclude, we should select patients for a future ECCO2R trial based on compliance, based on dead space, but not based on hypoxemia. This is how we might recognize who might benefit from ECCO2R. Thanks very much.